Good morning, everyone. สวัสดีค่ะ Welcome to the Smith&Nephew Symposium today นะคะ for the 360-degree shoulder masterclass in Bangkok. My name is Pallita Siripiyapat, Medical Education Specialist ASEAN. I'm so delighted to have so many distinguished sport med surgeons and faculty members today ค่ะ First of all นะคะ I would like to invite our Senior Business Unit Manager for the for the Sport Medicine Thailand to give us some speech and company mission. Please welcome คุณสุนิตา ชันนรงค์
And good morning, everyone. On behalf of Sport Medicine, Smith&Nephew Thailand, it is my great pleasure to welcome all of you here to our 360 Shoulder Masterclass. At Smith&Nephew, education is our thing, what we are doing, is our core of what we are doing. We strongly believe that excellent clinical outcome begin with high quality of educational and also continuous knowledge sharing. This masterclass reflects our mission and also our ongoing commitment to supporting you as a healthcare professional in advancing your own skill and also the important thing, improving patient outcome. It is now my great honor to invite Dr. Ekawit Geyurapan, the President of the Orthopedic Society for Sport Medicine, to deliver the official opening remark.
Thank you, Ms. Ying. Good morning, Professor Sukaya, Dr. Chiramsak, and many more. It's my great honor to be invited here. Firstly, I know Smith&Nephew 20 plus years ago. At that time, I started my career for shoulder surgery. For knee, Smith&Nephew is number one. I always use that until now. But for shoulder at that time, I have struggled for a while. The anchor at that time is not so nice. It's always pulled out. But right now, I think Smith&Nephew product is one of the best, which I like, especially the medial row anchors. I wish today we can learn from Professor Sukaya and our co-chairman, Dr. Manchai. He is on the way. And I wish everyone have a good time and please make a lot of discussion. Thank you. Okay, please.
So I would like to introduce our faculty member and chairman. So for our chairman, we are delighted to invite Professor Sukaya Hiroyuki from Japan. Our second chairman is Professor Banchachun Chujit from Thammasat University. And the last one is Professor Ekawit Geyurapan from Siriraj Hospital. So the session today will be the moderator for the session today is Professor Nathagun Kamthorn from Pramongkut Kao Hospital. And we have 3 speakers as well. The first one, Dr. Phakapon. Can you please stand up? Yeah. The second one is Dr. Lathapoom from Vethani Hospital. And the last one, Dr. Chanon from Payathai Navamin Hospital. Okay, I would like to go to the agenda today with you all. For the morning session, we are having the lecture topic and also the live demonstration by Professor Bancha for the RC repair. And then for the afternoon session, we are having the case sharing from our three speakers. And also we have the live demonstration by Professor Sugaya for the shoulder instability, bony Bankart and Lampisat. Okay, it's time to start. I would like to invite Professor Ekawit for the first session.
Thank you. My talk is about challenge for rotator cuff repair. This is the number of my cases. Rotator cuff is the green one. To me, it's 1/3 of my cases. I did collect the outpatient data and just retrieved it a month ago. I have rotator cuff cases, 7,000 something, which is quite a lot. And my surgery since 2005, I see quite a bit of cuff tear, small one, medium one, large one, acromioplasty. Right now it's more than 1,000 cases and more than 7,000 patients. I think the post-op result for rotator cuff repair to me is quite challenging. This is the cuff, and we all want the healing, like the right picture. But anyway, many times I have the case like this. I did a good job, but when I do MRI study, 1 year later, everything is the same. It's all gone. I think the clinical result and radiologic result may be different because many cases has a symptomatic re-tear, which I think if we do just surgery, but we don't know the result, it has no feedback to you. So I did MRI for almost every case if possible at 6 months to 1 year. To my best practice, for the full thickness tear, partial thickness tear, it's around 90% of the success. But for the massive tear, it's different story. The healing, the fully healing is around 1/3 of the case, whereas another 1/3 is partial re-tear. Mostly the posterior part will re-tear, but the subscap always heal. And also 1/3 of the case is complete re-tear. The poor result for the rotator cuff, the worst one is the symptom of the patient still persists, like the pain, stiff, weak, and re-tear. Mostly stiff. Some rare complication I found out is fluid extravasation, especially for the young surgeon. You may take quite long period to do surgery. My very first case, 3 to 4 hours, and one case has a fluid extravasation. Difficult to remove the tube for a day. Later on, it's also another rare complication from my fellow. She has a persistent of hematoma. Don't know why. It's come and go for 3 times. I plan to do revision surgery. Not sure the lateral row is stick to the area of a vessel or not, but it come like this. She feel pain. Luckily, when I decide to do revision surgery, but it's gone. Very, very lucky to me. I think the main problem for the rotator cuff is three category, which is pain, stiff, and weak. The first challenge is the pain relief. I think since we have many young surgeons, I think this is very important. We need to choose the right one to do surgery, because there are many sources of pain from very superficial like skin, subcutaneous, muscle, tendon, deep down to the rotator cuff. So many causes of pain. If the patient come with shoulder pain, with impingement sign, and you go for surgery, you might end up like the case I show you later. This is the example of the case. He followed with me for 15 years. He has only half of the subscap and teres minor. He do really well. This is X-ray picture and MRI more than 10 years. It's still very good, and he don't need any kind of surgery until now. So recently, I found this case because maybe I'm a referral center. This case is 35 years old lady. She has a right shoulder pain for 1 year. She had to steroid injection and did MRI study for 2 times. So I think 2 times because the surgeon who did surgery may still thinking this is the right case or not. Anyway, she was underwent rotator cuff repair, decompression 6 months ago, but still have pain. Probably surgery didn't help for this case. Only 35. Very rare to do a chromioplasty in 35. I do have some cases that really have a tear under 40, but it's less than 10 cases for my series. So for young surgeon, please think twice before you jump to do surgery. Otherwise, it's end up like this. But for this case, after I do truly physical examination, it's just a tendinitis. If you stretching long enough, maybe 3-4 months, she will be better. So for the case, I think if we plan to do surgery, the lesion should be the one like this, big tear, small tear, but at least more than 50% of the thickness. This may be a good candidate for surgery. But if you find some case like this is very often you may see the patient with severe shoulder pain, MRI show the articular side tear like this. If you keep patient and follow the patient long enough, it will show up the stiffness. So on the left picture, I don't do surgery for this kind of patient. Oh, our co-chairman, here you are. We are waiting for you, but the time is quite running out, so I go on. And also the other cases is just a tendinosis. For this kind of case, if you want to do surgery, you have to think twice. Maybe that's not the main reason of the pain. Next is the second challenge, the stiffness. There are 2 kinds of stiffness, reversible and non-reversible. For non-reversible, like DOA, and if you have a rotator cuff pathology, it depends on the age group and also the patient data that we need to retrieve, whether we're going for arthroplasty or we still can do repair. But for the reversible one, which is frozen shoulder, it's quite interesting. So for the frozen shoulder, if it's the early phase of the capsulitis, it may show the clinical really similar to rotator cuff. But in which case we need to do surgery? I sometimes do both surgery, which is repair and capsular release, for the one that have rotator cuff tear big enough. In that case, I will do capsular release first and go for rotator cuff surgery. The big tear like this or small tear, but with full thickness, I will go for surgery. But if it's just maybe 50% of the thickness tear, I wait. Why I do this? Because post-op, I still need immobilization, right? But if I do just cuff repair without release, the patient still have pain. And about the technical of the repair, if you do not release the capsule, the subacromial space very narrow, so it makes you do surgery very difficult. Sometimes why I do the subacromial work is too narrow, too tight. I cannot get a good traction, so I come back and release it, and I go to the subacromial space and do it again. Okay, next is the third challenge. The weakness from the full width tear, that's quite common. If you see the patient with the rotator cuff that has weakness, should be something significant like a full width tear or maybe the nerve problem. If it's come from the fluid tear and you want to gain the strength, you need the heal tendon. If the tendon doesn't heal, the power will not come back. How to improve the healing of the rotator cuff? I think there are many factors. The patient factors, surgeon factors, like the age, chronicity, the tendon quality. Some case, I did very good repair for the large tear, but it's failed. I don't know why. But if I think back, those kind of patient, I think the soft tissue around the tendon is not so nice. The bursa is gone. So this kind of case is really easy to do surgery because everything is clear, but not good for healing. So even though I have maybe experience like this, I have a good technique, but for my best practice, I still cannot get 100% of healing. Like this one, sometimes it's still retear. I think for the next step, it's time for biologic augmentation. This may help me for improving another 10% of the case. Hopefully, this may be the answer. So I pass from now to the next speaker. Thank you.
Okay. ไม่ดัง Next session will be from Dr. Shannon in the topic of what is regeneration.
Sorry. Okay. Good morning, respect professors, my dear colleagues, and other guests. I'm Dr. Shannon from Payathai Hospital. So today I would like to talk about our implant. Regenetain is a bioinductive implant and its role in tendon healings. So let's start with the key property of these materials. Okay, about the Regenetain bioinductive implant. This is a type 1 collagen scaffold that's highly purified and is highly porous with well-aligned structures. So this specific design is important as it helps stimulate the body's natural healing response. As a result, it supports the formation of new tendon tissue, essentially guiding the regeneration process. Notably, tendon-like tissue can be induced within approximately 6 months. Okay. So this is where it comes from. This implant is made from type 1 collagen and it comes from the bovine Achilles tendons. So it works well as a scaffold for tendon healings. So it acts like a scaffold to let the cells from the body to get in. And the next picture is the microscopic view. So we can see that the collagen and fiber is highly organized and well aligned. And they also have the porous structures, and this small space allows the tendon cells to grow into the implant. And then they multiply and help support the healing process. And in the end, they become the tendon-like tissues. Okay. So this implant is basically placed on the dorsal side of the rotator cuff. So we place it after we repair it, or maybe we can use it in the dorsal side with partial tears. And then it creates a good environment for tendon healings, and it absorbs within 6 to 12 months, depends. Importantly, is bioinductive, so meaning it stimulates the body own cells. So they induct the healing, they promote healing. They induce the cells to get in. It's not act like the patch. So it's not really have the mechanical support. It's just the scaffold to promote healing. And in the end, they become another layers of the tendons. So it's not like another patch or dermal patch. Here. Okay, so sorry. Okay, so let's see this slide show about what happened to the implant over time. We divided into 4 phases. The first one is rehydrate phase, recruit phase, remodel, and recover phase. The first phase, the rehydrate phase, is happen in the first month. So the rehydrate phase, the implant will fill with blood and surrounding fluid, including the body cells. And the porous structures allow the body cell and growth factor to enter the implant. As I said before, they act like a scaffold. So this phase will let the cells and the blood to get inside the implant. And then they start the healing process. The next phase, we call it recruit phase. It happens at the first from 0 to 3 months. The body cells, mainly the fibroblasts and another like healing cells are will attach to the implant through the porous structures, and they gradually absorb the collagen and replace it with the new tissues, forming about like 2 millimeters thin layers. Okay, come to the next one. The next phase we call the remodel phase. It's from 1 to 6 months. The new tissue is exposed to the mechanical force, which means they gradually become more like normal tendon. From the past, the cell get in and the implant is started to be thicker and become the more normal tendons. And the last phase is after 6 months, we call it the recovery phase. A new 2 millimeter layer of tendon-like tissue has formed, so it helps reduce stress on the rotator cuff and also support healing and allow the patient to return to normal activities. So here is the graphic overview of each phase. Each 4 phase, the rehydrate phase, recruit phase, remodel, and at last recover phase. And also this slide shows the histology of the healing process. At 5 weeks, you see the first pictures. The upper one is our implant. Still have no cells in it, and the below one is the native tendons. So the cells is gradually get in. They migrate into the implant that act as a scaffold. And the fibroblast move into the porous collagen implant, and the next one is the next picture at 3 months. The implant start to dissolve, and finally, at the final pictures in 6 months. So the histology view is become more like tendon, to become another layer of the tendons. So this slide is also show the difference between regenerative and the dermal patch. The difference point is the regenerative induce the new tendon-like tissue formation. As I speak before, they are scaffold. They let the cell coming in, and then finally they become the new tendon-like. And in contrast, a dermal patch mainly provide medical support immediately after we plant it, but there is no inducing or new tissue modeling. So that's the difference. So this one is I let you see the video of the regenerative. เสียงไม่ออก
Rotator cuff tears are increasingly common as people get older. Traditionally, they've been repaired using biomechanical techniques, but studies show that these repairs can re-tear up to 40% of the time. Smith&Nephew takes a different approach, focusing on improving healing and avoiding re-tear through innovative technologies that work together to redefine biological healing in rotator cuff repair. To begin the advanced healing rotator cuff repair, helicoil Regenesorb anchors are inserted on the medial row, using an awl or threaded dilator first and then screwed in. These anchors support healing through a unique open architecture design that allows access of bone marrow and growth factors to the repair site. Mini-tape suture from the medial row is then passed through the tendon using the first pass ST suture passer. For the lateral row, the mini-tape suture is passed into an open architecture helicoil knotless anchor prior to insertion. The Regeniten implant is inserted over the repair and fixated using tendon and bone anchors using its unique arthroscopic delivery system. The Regeniten implant has a highly porous and bioinductive design, which allows rehydration with blood and the body's own cells. As these cells enter the implant, they attach to the implant's fibers, beginning to digest it, producing new native collagen in its place. Through the motion of the shoulder, this new tissue becomes tendon-like, increasing tendon thickness by 2 mm and reducing the load on native cuff tissue. This new tissue has been shown to aid rapid recovery and reduce re-tear rates compared to the standard repair, ultimately helping patients get back to what they love.
Okay, so this is all of my sessions. Thank you.
Okay, our next session is the case sharing by Professor Sugaya from Japan in the topic of partial tear and full thickness tear repair with Regeniten.
Thank you. Good morning, everybody. I'm very happy. Thank you for inviting me, and I'm very happy to share time with my Thai friends and also former fellows and Thai young doctors. And I'd like to, share experience of the using Regeniten. Okay, so what I expect to do Regeniten is to prevent, of course, to prevent post-op failure in shoulder with a repairable rotator cuff. But I think especially my concern is large degenerative tear and suboptimal tissue quality, even if it's repairable, and also the partial thickness tears, irreparable partial thickness tear, and also the patient who requires some specific technique like muscle advancement or extreme measurization. So for this kind of patient, I'm using Regeniten. So I will share cases. The first case is a repairable hip thickness tear with suboptimal tissue quality in elderly patient. This patient is a 76 years old female. The history, left shoulder pain since November 2022 with a traumatic episode. Pain and motion worsened from January 2023. And physical examination demonstrate the range of motion is okay, but the pain and the weakness on elevation. So this is pre-op MRI. MRI is in a medium to medium-sized rotator cuff tear. Muscle atrophy is not so severe. So I thought that even 76 years old, I thought that this tear can be repairable. So I repair rotator cuff arthroscopically, like this. I cut the biceps. I performed biceps tenodesis. And I repair like that. But, this, to me, it looks like, suboptimal tissue quality. So that's why I put the Regeniten on it. Like this. Then outcome is a post-op MRI 3 months after the surgery. The MRI looks very nice. 6 months, better, good. And 1 year after the surgery, very good. And also 2 years after the surgery, even Gaia type 2. So it's very nice. And the patient's very happy and doing very well. Second case is the irreparable pressure thickness versus side tear. Sometimes we experience like this patient, like this case. Patient is 78 years old male, history right shoulder pain since fell on the shoulder in January 2021. And the pain on motion got worse since April 2023 and they referred to me and TSOC. And physical examination demonstrated the elevation is severe limited, only 60 degrees active elevation with pain, and the external rotation is 30 degree, and the AD action is the sacral level. So pain and the weakness on motion. So MRI shows the not big tear. This is a maybe bursal side tear, like this. And actually, I tried to repair this, but I cannot cover the hurry. So that's why I put the regeneratant on it. Then 3 months after the surgery, very good. 6 months, very good. And 1 year after surgery, very good. This is, I think this is type 2. So he's very happy and he's doing very well. Okay, third case is we utilize the cases with calcific tendinitis, especially when the calcific tendinitis is big patient, right? This is a pre-op MRI, X-ray, and a pre-op CT scan. And this is the video during surgery. We remove the calcium tissue. And always after taking out calcium, we have this kind of defect, bursal side defect. So this defect not so big, but I place one suture, I place one side-to-side stitches. But I think it's very difficult to close the gap 100%. So in this case, I also put the regeneratant on it. Okay. So this is post-op X-ray. Oh, sorry. Post-op X-ray and post-op CT scan. Calcification disappeared 100%. And 6 months after the surgery, post-op MRI looks amazing. So my indication for calcific tendinitis, my indication for using regeneratant for the calcific tendinitis is mostly large calcific deposit with large defect after resection, like this patient. So since January 2025, I used in 24 cases for this kind of patient. And the average age at the time of surgery was 58 years. So I think that this this is also one good indication for regeneratant. Okay, another case, the large degenerative rotator cuff tear, the muscular advancement case. This patient is a 69-year-old female, right shoulder pain and weakness since November 2023 without trauma. Presented with same symptom on March 2024. Physical examination demonstrates in the range of motion is okay, but the pain and weakness on elevation. So this is the MRI, relatively large tear, 69 years old female, and the muscle atrophy is present, but this is not Guattari stage 4, maybe 2 or 3. So I think the muscle still remains. So the muscle advancement, I will speak about the muscle advancement and the extreme medialization during my next talk. But this is my muscle advancement case. So first, I release the standard release. I perform the standard release and capsule release or something like that. And also, I release the suprascapular nerve, transverse ligament first. And I release the muscle, rotator cuff muscle, supraspinatus from the scapula fossa, like this. and preserving the connection of the rotator cuff muscle and rhomboid. Okay, after entire supraspinatus muscle release, mobility improved like this. Very nice. And after that, I proceed to the release of the infraspinatus muscle, preserving the junction between the infraspinatus and rhomboid. So after that, I performed the suture bridging repair, and finally I add regenerative. Like this. Okay, the outcome is in the post-op MRI 3 months after the surgery, it looks good. 6 months, it also looks, in the muscle tendon looks a little bit thin, like a Gaia type 3 or something like that, but I think the continuity is very good. So this is 1 year after the surgery, type 2. Okay, the last video I will share the case of the extreme visualization. That this is a 64 years old female, right shoulder pain and weakness since May 2025 during volleyball. She really loves to play volleyball. And the physical examination demonstrates range of motion is okay, but pain and weakness on elevation. And she had a history of surgery, the right cuff repair, arthroscopic cuff repair back in 2010 by a doctor. So this is pre-op MRI, the human head superior migration, and also the marrow anchor is already inserted to the greater tuberosity. And a muscular atrophy is significant, but not Gutaria stage 4. So this is the extreme visualization. Extreme visualization is the removing the bone tissue at the greater tuberosity, not the greater tuberosity, the superior humerus, like this. So remove the bone tissue, and after standard mobilization, cuff mobility looks nice. And so this is after repair. And finally, I put the regenerator on it. Okay, this is after the surgery, the X-rays, and you see the bone tissue at the greater tuberosity was resected like that. So normally the chronic rotator cuff tear in a human head getting bigger. So that's why I think this is a very reasonable technique. Okay, so I want to share one interesting case, a case with severe positive reaction, synovitis. So many doctors who are using regenerative discussing about experiencing the synovitis like this case. But some goes to the surgery, but my case was I just observed and the synovitis disappeared. So this is very interesting. 58-year-old female and a post-op MRI. This is pre-op MRI. This is 3 months after the surgery. You see the synovitis around the rotator cuff, vasa. And 6 months after surgery, the synovitis was very severe. You see, do you recognize that? Is there a pointer here? Which is pointer? Can you go back to slide? Three months. Go back to 3 months. No, no, no. Yes, yes. Very difficult. Okay, these are synovitis. 3 months after the surgery, and 6 months, synovitis. Time I wonder we should go surgery or not, but our symptom is not so painful. So that's why we saw. Then synovitis getting better, and 1 year after surgery, disappear completely, and also half the symptoms very good. So no complaint. So that's why maybe if you experience the synovitis, maybe the symptom, if the symptom is not so severe, maybe you can observe the synovitis cases after using Regeneten. Okay, this is 2 years after surgery. She's also very happy. Okay, overall result, the 1 year result after ALCR with Regeneten. Actually, we started using Regeneten more than 2 years. And 1 year follow-up was 25 patients, 14 males and 11 females. Our average age at the time of surgery was 63 years. The tear size was pressure thickness tears, 4 cases, small to medium case tears, 2 cases. And mostly I use large and massive rotary cuff tears, 19 cases. And repair integrity, we checked the repair integrity using MRI, and the partial tear, all 4 cases type 1 or 2, very nicely healed. Medium-sized tear, 2 cases, type 2, very good. And the large tear, 11 cases type 1 or 2, but 2 cases type 4 or 5, big tear. And the massive cases, 1 case type 2, but 5 cases, mostly type 5. So that's the healing rate was 72%. Okay. And the 1 year result after advancement with Regeneten, we used 5 cases, 2 males and 3 females. Average age was 67 years old. Tear size was large tear, 1 case, massive tear, 3 cases, and a revision massive tear, 1 case. And outcome is we had a type 5. 1 case is massive tear, and also revision massive case type 4. So that's why healing rate was 60%. I think considering the revision or large and massive tear, this is not, this is, I think, very acceptable outcome, but, not ideal. So that means, even using Regeneten, we cannot prevent a post-op tear, re-tear, especially large cases, large part quality cases. That's very important information, I think. To summarize my talk, my indication for using Regeneten, the irreparable partial thickness tears and the irreparable full thickness tears with suboptimal tendon quality in the elderly patient, and the muscle advancement cases and extreme visualization or something like that. But the structural integrity was acceptable, but still higher return rate in the large and massive tears. Thank you for your attention.
Thank you.
อาจารย์เชิญเลยค่ะ
Any question from the floor, please? If not, can we go back to the slide at 3 months? I saw some signal. It's like a sheet. Is it possible that the Regeneten was loosening or it's fall off? Please go back to the 3 months slide. The last cases. Okay, go back. Yeah. You see the signal of the very thin patch above the tendon. Yeah.
Might be possible.
Mhm. Any report about the loosening or discharge of the regenerative from your side?
But I think my fixation is
Secure, right?
Yes, secure.
Yeah.
But I think the part of the kind of reception
Mhm,
process or something like that.
Mhm.
This is a very interesting case.
Yeah. Very interesting. So anyone have experience using the regenerative and would like to share? Please. Dr. Op, you smiling.
Good morning, Sigaya. I'm Dr. Sangpet from Ramatipati Hospital. I have just a little experience about it, but my question may be out of your example cases, like if you have a large tear, that you can retrieve all the suture to the edge of the footprint, but it's quite a very large, and the size of regenerative is just limited. Do you have any idea about that? Where is the location of the regeneration should place on? Or is there any possibility to use two pads in the same time? That may be a funny question.
2 packs, too expensive, I think.
Sweet love you. You put on just the tendon part, or if it's a defect like the last case, you have a raw bone. You will put it over the bone.
Yeah, I expect the muscular advancement or large tear case, like extreme medialization, tendon cannot cover the entire footprint. But instead, do you know the Steve Schneider's Crimson Duvet? The tendon, growth factor comes from the bone, and if the tendon was reattached to the medial side of the footprint, and at the end, tendon-like tissue, grows in the 1 year or 2 years after the surgery. So that's why I expect like a Crimson Duvet like phenomenon using the regenerative. So that's why I put the regenerative on the maybe. So this is the posterior side is okay, right? But front side is a little bit defect. So that's why I expect the fitting of the tendon-like tissue by using regenerative. So that's why I only use one regenerative, one set. Okay.
So you did the MRI study 3 months, 6 months?
3 months, 6 months, 1 year.
1 year. So at 3 months and 6 months, you see some change of the regenerative, right? It's going to resolve within maybe 6 months.
Normally, I cannot detect the regenerative itself, like the previous case. We cannot see we cannot distinguish the tendon from the regenerative. 3 months, 6 months, 1 year.
Hello. Can you hear me? Bancha speaking
Yeah.
from the lab.
Yeah.
Okay, so very nice talk. So Hilo, I have a question for you.
Okay.
For the calcium deposit, calcific tendinitis.
Mm-hmm.
So when you put the regenerative in, you have any reaction because regenerative have some effect of the stimulation of the healing.
Mm.
So in your practice, you have any problem with the over inflammation after the surgery?
Oh, we're now discussing about the synovitis.
Yeah.
Yeah.
Yes, right.
I have one case with severe
Yes.
synovitis after putting Regeneten. But synovitis
Yeah.
disappeared without doing anything.
He just
Yeah.
asked me about the calcific tendinitis case,
Yes, I
which,
know.
which has a lot of
Yeah.
inflammation of the bursa.
Inflammation.
How about you? You have any problem with the severe inflammation in the calcific
After that.
tendinitis case?
My indication of calcific tendinitis is that I always do surgery after subsiding inflammation.
That's the
So
reason.
that's no pain. Patient doesn't complain any pain, but also only complains motions flow and only complains catching, mechanical catching.
Okay.
So that's why no inflammation. So that's why I don't
Different cases.
experience
Mhm.
like that.
How about you, Dr.
Okay.
Bancha? You do
Yeah.
surgery in the inflammatory phase.
Yes. No. Calcium deposit, mostly I try conservative. I did a lot of injection, steroid. But like Hilo said, I agree. When you fail conservative, you can do the surgery. But I myself never tried the Regeneten in calcific tendinitis. So that's nice to know that. Yeah, because sometimes we're dealing with the problem after the surgery, we have some defect. After you remove the calcium, you have some defect and sometimes the tissue is bad. Okay. Thanks, Hilo, for your sharing. Yeah, that's the new indication for me. Thank you.
I agree too, because some case with very large calcium.
Yes.
For that case, I try to avoid surgery because I don't know how I can cover if I remove all the calcium, very big one. But we may
Yeah,
try
right.
the new technique for that.
Yeah. That's nice to know.
Mm.
Thank you.
Okay.
So Hilo, in conclusion, your indication, because I leave the hotel a bit earlier. So can you conclude again your indication for Regeneten for the young doctor and also for us? The summary of your indication.
Yeah.
Can you go back to his slide? I think very last slide. He showed us
How many indications?
That's right.
last slide สุดท้ายจ้ะ
Poor tissue, revision surgery.
Yeah. Can you
Yeah.
see it, Dr. Bancha?
Yes. Can you see that?
Where is the monitor? Yes.
The irreparable partial
Yeah,
thickness
right.
tear is a very good indication. And the reparable thickness tear is bad with suboptimal tendon quality in an elderly patient. And also the large tear, who requires muscle advancement or extreme medialization kind of things.
Yes.
That's also, I think, my indication.
So Hilo, how about the articular side tear? Because I heard from my friend from Spain, he also do that in articular side tear or pasta lesion. What do you think?
Yeah, I don't believe that. But, I tried one case. So I see the results.
It's good or not? You laugh.
How about revision surgery? Do you think that it needs to have some kind of
Revision?
revision?
Yeah, of course. Yeah.
Right. Did you try any injections add on like the BMAC or any PRP after?
After cup repair, you mean?
After Regeneten placement?
Oh, no.
Maybe too much.
Too expensive, I think. Is it okay?
Okay, I think it's time.
Let's go. So, good morning, everyone. I welcome Professor Sugaya for coming to Thailand for this event. Thank you, Smith&Nephew, for organizing this live surgery and also the meeting. Okay. So first of all, I would like to introduce our team. We have my assistant, Dr. Seksan, is here, and David from Philippines, my fellows, Dr. Mohanad from Jordan, Yeah, and Dr. Sun from Phang right? Sek Sun, he's Thai. He look like Jordan, but he's Thai. Okay. So, first of all, this is a very good, great teacher. We call our cadaver great teacher. So we already preparing something. So first of all, when we put inside the joint, yeah, this is bicep. It's nice. The tissue today is very good, and this is the torn supraspinatus. Okay, you see that this is the complete full thickness tear. So I always put my suture to identify my bicep, so we can know the most anterior part of the supraspinatus. Okay, so here when you get into the subclavian space, you can see where is your bicep. Okay, so then I switch my camera. Now I in the jaw is good, subscap is okay, and the cadaver is very nice today. Yeah, we got a very nice cadaver today. So I switch my camera from here, okay, to the subclavian space. Okay, for the portal, yeah, I showing you we have posterior portal, right? And this is my viewing portal. I always put my viewing portal a bit higher. So we divide the acromia into 3 parts. Okay, the posterior 1/3. This one is my viewing portal because I will stay very high, like we got the bird eye view. Okay, like this. So this is my viewing portal. Okay, and my posterior portal will be coming from here. Okay, so this patient, you see that the patient have some bone spur here. You see on the top here. So this patient, if you look at this acromion, it's not nice, sharp. So if you did not decompress, your problem is that the cup will be torn. I show you the cup morphology. This is a nice case for regenerative. You see the tissue? Tissue is very bad. I mean, yeah, Frank, this is a good indication to put the regenerative on the top. You see? The tissue has a lot of some small hole here, another holes, and that one. So this is a good indication to do the regenerative biological augmentation. Okay, you agree, Hero?
Yeah.
Ekavit,
Yes.
you agree with that with me,
I
right?
agree
Yeah.
with you.
This is a good indication. Okay, and I think this patient I need to decompress the spur. So some surgeon did not decompress the spur at all. Like Dr. Thanatep, you there, right? Thanatep, you will decompress or not in this patient? Thanatep,
He said he will.
Thanatep,
He will.
he will, right? Nata, you decompress or not this patient? Nata, you
Already.
there? I saw
Yeah,
you.
yeah.
Of course, right? Okay,
course.
good. Thank you. So then I switch my camera to the subocciput space. So here you can see the spur is there, right? It's bad. Yeah, very sharp spur. So acrominizer, please.
So you always
So-
will the spur from the back.
Yeah, we always spur from the back. Okay, and also we always check our X-ray. Okay, so I identify my AC joint. Yeah, here the AC joint is there. You see that? That is clavicle. Okay, so we draw the line from the clavicle. It should be in the same line. So this is the line of the clavicle. Okay. Okay, then we make a drawing first. So for the young surgeon, you should water. You should know how much you need to decompress, right? Yeah, first I remove the spur parallel to my distal clavicle. Yeah, you see the tip of the spur is very bad, right? So I clean this, take this out. So I view my spur from both view. I will first looking from the posterior view, identify the clavicle, draw the line. It should be in the same line, okay?
So your
And
reference
then
is
I switch.
your reference is distal clavicle, right?
Yeah, distal clavicle.
What?
So some spur is very easy to identify because they have the like the hook spur. You can see the base of the hook, right? It's easy. But some spur is maybe difficult to judge. You can identify the distal clavicle as a reference. Yeah.
What if the distal clavicle has a spur also?
Yeah, that's right. So if the spur of the distal clavicle, I will remove the AC spur first, okay? And then I can see the native distal clavicle. Yeah. So here, after you take this out, yeah, it should be this line, okay? So after you take this out, I will preserve my CA ligament. I just detach it from the C element from the from the acromion, but just peel off, don't resect it. Yeah. So after decompression, then we switch our camera to the lateral side. Okay, now you can see that now we are flat now. And also I like to do lateral bevel like this, yeah, to reduce the critical shoulder angle. Okay, this way. So now this is flat, and you see it's parallel to your clavicle. This is your clavicle. Okay, it's in the same line. Okay, then we switch our camera to the lateral side. Okay, and you see that if you're looking from one view, it's not enough. You need to look from that lateral view also. This is like you do the supraspinatus outlet view yellow. Yeah. You see here, now you remove the anterior part, but this part, you use the posterior as a reference, right? Here, you can see the spur is still there, okay? So we need to take this out also. So always look from both view because one view is not enough to decompress the spur. You see here, it still look bad, right? And this is a clavicle ecovit, you see? It should be in the same line, okay? Acrominizer. So after this, đừng show hết từ. Okay. So that is my acrominizer, yeah. Traction cap. Okay, use a posture as a reference. Yeah, this is a posterior acromion, right? Ibosa. Okay. So now it's parallel to your posterior acromion, right? So I think if the patient bursal side tear or there's some abrasion of the cup, you're always looking for the roof of the shoulder, right? I don't agree that we not routinely not decompress because some surgeon is very they are very straightforward. They don't decompress at all. I think we need to judge the patient one by one. Okay. Okay, that's good. Then clavicle is there. Okay. So now you see it's good now. Yeah. So next step is I will look at this and switching stick, please. Yeah. I use this posterolateral weaving portal. So routinely, I have 4 portals for my rotator cuff repair. We have one in the back, and yeah, now you see it's flat now. Yeah, the acromion. Yes. If again, you see a spill here, right? You see here, it still have a little. Yeah. Okay. Traction. Okay. You see here. You see, yeah, this is posterior acromion. You still see the spur. Here. I think this is the part of the success if you make a very nice acromion decompression. Yeah. So then next step is we'll do the biceps after this before we start to do the cup repair. But this one, the bicep is good. Okay, that's good now. Okay. Here you see you have very flat acromion now, right? From the back to the front. Yeah. And also you have enough room. You see here? Can you make Hawkins sign? Hawkins. You see? Yeah, internal rotation too much. Again. Yeah, you see? If you have spur there, the spur always exlow. Internal rotation. Okay, you see? Your acromion is very close to your rotator cuff. If you did not decompress it, yeah, of course you will the shoulder will be damaged. The cartilage, the rotator will be damaged after the repair. Yeah. Okay. Good. Now I think the loop is clean now. Next step is to do the rotator cuff debridement. Shaver, please. Okay. So this is a torn rotator cuff. I clean my tuberosity. I use the shaver most of the time. And you see there's a cyst here also. You see the bone cyst? Yeah. So many times the patient with impeachment will have bone cyst. And sometimes the cyst is the problem. Yeah. But this patient, the cyst is not at the footprint. Yeah. You see the footprint is there. This is a microfracture. I always do microfracture to promote the healing. This is another biological augmentation. Yeah. Okay. And this step is important. You need to clean the bursal very well. I call white crew, right? You need to make this very nice before you start to do the repair. Okay. Okay. Remove all the bursal tissues like that. Okay. And cleaning. Sometimes you have a lot of the bursa, especially in the back. Okay. Here I show you. We're going down there. Okay. So you can see this is the infraspinatus. And also you can see axillary nerve will be there. Okay. Very close to your teres minor. Yeah. So actually we don't need to go that far. Okay. So next step is to do the tissue preparations. So if the patient also have the very stiff or very big tear, I always going to the front here. IF please. That is a conjoint tendon. Yeah. Subcannula. No? So if the patient have very tight, yeah, you need to do some release. That is collocoid process, yellow. Okay, you go under the collocoid process and release the collocohumeral ligament like that. Okay, so here subscapularis, you see here subscapularis. If you have torn supraspinatus, also the subscapularis and very big tear, I start my release first. Yeah, to make better mobilities of your calf, right? Yellow. Okay, nice. That is collocoid process, right? And we can delete this part. This is the collocohumeral ligament, yeah, to free your tendon from the collocoid process. Okay, yellow. Okay, and that is the C ligament. Yeah, I still save it. This is the C ligament. Stop. Okay, nice. So now we're going to the tuberosity. So the middle row today, we are preparing the Q fix. Yeah, external rotation. Okay, very good. Shaver, please. Okay. So my tear here, I find the footprint, right? That is the supraspinatus attachment. So if you have no bicep, that's fine. But this one, you still have bicep attached, right? And that is the bone cyst. So I plan to put 2 anchors for the medial side and 2 on the lateral. Do you agree, Natha? Ekavit? You put 1 or 2 on the middle row. I know Ekavit like to put 1 because he always save the money.
For medial, two is fine, but lateral maybe 1. But it's depends.
Lateral 1, right?
Yes.
For the medial, you put 2,
Two.
right? Ekavit. How about Natha? Ta?
Yeah, 2 for medial, 2 for lateral.
What's that ta?
2 for medial.
2 and 2, right?
Yeah.
And hilo is 3, right? I know that you make
2 and
triple
2.
low.
2 and 2.
2 and 2. Thank you, Hero. Okay, good. So,
And what is your landmark for the first and second anchors?
okay, so I show you here. Now we find the switching stick. So my portal here, I just put it in front of my AC joint here, okay? And my landmark will be here. This is my first one, okay? Next to the cartilage. But if the patient have very big tear, sometimes I do a bit medialized like Hilo lectures today, right? But here I think the cup tone is, we can put it anatomic, yeah? One for in the front, okay? And the second one will be here, Nata, okay? You agree? One in the front,
Here,
one in the back.
When compared with
And
the
this one.
facet of the greater tuberosity, can you explain me more?
Yeah, so for me, I never see that facet. I mostly look at the tuberosity and I try to distribute my suture uniformly. So I put one in the front, one in the back. Okay, if the thigh size is this big, but it's a small size, I will put one in the middle. Okay. So
in this case,
give me
maybe I
the
put
Q-fix.
3. In this case, it's quite big.
Oh, really? Yeah. So this is a Q-fix knotless. Okay, remove this. You do this one to identify your landmark, right? ต่อเบาๆต่อเบาๆเร็วๆ Con bar. Okay, here. You agree? And the angle, I prefer to go a bit like this, right? Not to, it will not slip, I think, this way. Okay, let's go. Okay. This is a cubic knotless, right? So the pilot hole is small, and then you slowly turn this. Can you hear the pop? Yes, one. Pop. Okay, two pop, right? So that's another company. Another company also have the pop, but different pop. You don't mix up, okay? Different pop. That one is pop something, right? But this one is the cubic knotless. I show you, okay, pulling, okay? I pull very strong. Section, can you show? I not pretend to do that, okay? You see the shoulder shaking, right? So that is very strong. Trust me. It's become a big ball, 5.5. Hilo, you like that? Hilo, you like this?
I love you.
You love it. I love you too. Okay, then I do the internal rotation, okay? So this is the benefit of the beat chair. I and Hilo do the same. We do beat chair, but Ekavit, he is the decubitus guy like Shanakan, right? So he cannot rotate the show that, okay, stop. Yeah, that much. Okay, let's go. So you see the direction is good when you rotate the arm using the same hole. ชนยังวีดูดิชนยังวีชนยังไป let's go เอาวีไป go
Dr. Bansha. Dr. Bansha.
yes yes pop up right
Yes,
Uppy
you know
my beloved
name.
brother
Yeah, I love you too. My question is that how can you choose between the anchor with the suture anchor or the something like that you use, the knotlets?
again I cannot hear you well
How can you
Up.
choose what decision making that you use for the knotless or the one with the regular one?
okay I actually I like this soft anchor in my practice for the middle row. I don't like the big anchor that you need to tap, right? In my practice, that honestly. So I prefer the soft anchor. And up, you know, the many studies prove that the name is soft anchor, but actually it's strong. Yeah. So for me, I don't like the big anchor.
I agree, but you
I
have
prefer-
any question? You have any trouble about the
Pull
soft
out.
bone? The soft bone.
No, when we have the soft anchor, I just put it in the subchondral. Yeah, and because if you make a pilot hole, you weak the bone, right? I prefer to put the soft anchor in soft bone. Yeah, it's a bit weird, right? But that's true. Trust me. เอาผิดเส้นอีกหาเลย sorry ไอ้เชี่ยมึงจับทำไมเนี่ย
อาจารย์บัญชา
sorry
อาจารย์บัญชา
sorry I'm ครับ
I ask you more about helicoids because helicoid promote
are you Dr. Thanatep, right?
I think so, yes.
You do the rotator cuff in 15 minutes. I heard that.
Yes, that's a that's a myth.
You did not clean all the bursal tissues, right?
Yeah, I think it's
Very good. Internal
okay. So my
Yes, yes.
question is,
What's your question?
my question is helicoid promote that they have a good ventilation, so vent for bleeding and promote healing at the attachment point. Do you agree with that?
Yeah, I agree with that. I agree.
So comparing to the,
But,
true soft anchors.
Yes, but honestly, I use that sometime, but I need to make sure that the patient have good bone. Yeah. So helicoid not less is the anchor is like Bruce and you the bone can get into the anchor, right, for the healing. Yeah, I agree. Call mini first. Okay, so for me, I try to make less knot. You see, my first one, I do one, to my posterior part, sometimes to the junction between supra and infraspinatus. So the second one, I put 3, right? This is, we go 1, 3, 3, 1, okay? The second one, I try to go to the good tendon, here, okay? This one, you see the first one, this is the second one. Yeah. And the gap between the first one and the second one should not be too close. It should be around 7 to 8 millimeters from the study. If you less than that and you tie the knot, you can create the type 2 tear, okay? Do anchor, do cannula จัง cannula มันปิดอยู่ Suture retriever. So this will be my shuttle. จับดิ traction. So this is my shuttle, okay? จับนะ cam. Okay. So I make it 2 times first. Send it up. This one. And then I make the Ethibond as my shuttle because this will become a loop. Okay. And then I pass this suture, 3 suture, okay, into the same hole, right? So that will have suture retriever, have less trauma to your cuff. So you make too many holes to your cuff, it's not good. Your cuff will get strangulated, okay? Like that. Okay, next one.
Dr. Bancha, you plan to use
Yes.
the knotless, right?
Yeah, that will be knotless and knotted, okay? So, branded, we call branded suture bridge, right?
What's the concept of the knotless?
The knotless is I think you have knotless, you have less tissue strangulations. You can distribute the suture to have the good contact healing. But if you did not make knot at all, there will be no compression on the midsection. There will be no compression on the medial footprint. Okay. So I'll show you this one, right? This is my sutures. Okay, or suture. Up I pull. Okay, this one will become the, this is my suture. Okay, the next one is the anterior anchors. ดึงเชือกดีๆเส้นเก่าดึงให้สุด Okay, this one, 1, 3, This one 3, right? 1, 3. This 3, right? 2 tiger blue and 1 black. Okay.
So before you
Go.
proceed to the anterior anchors, can you explain
Yeah.
a little bit more for the configuration?
Yes,
For
of
the
course. I
posterior
will
one.
draw the pictures for you. Suture retriever. Give me a paper and the okay, that's one. Okay, last one. Suture retriever. Đừng hít sụt đi. Sorry, sometimes get angry with my fellow. Em muốn đừng hít sụt đi. Đừng hít sụt. Đẹp lại. Okay. But I heard that Hilo, you're very kind to your fellow, right? You never shout.
Yeah, I sometimes sing a song, but never shout.
That's good. Doobie brother. Son said, son used to stay with you. Doobie brother, right?
Yes.
Your favorite song. Okay. You like it? It's good. So now I will show Ekavit. Give me a paper. Hold this. ปากกามา กระดาษปากกา Okay. So here, can you see? Here. So this is the curve, right? We have 1, 3, 3, and 1. Okay. So this is for the medium-sized tear. So this 3 suture, I will make 1 knot here. Use the posterior as the post. When you tie the knot, use the posterior. This will become 2, right? And this 3 suture will become 2. Okay? And make 1 knot. So the suture will be like this. Okay? So this 1, 3, you tie the knot, but you use the anterior as a post. So this will become 2. And this 3 will become 2. And finally, you will get 2, 2, 2, 2. Okay? And the gap between this will be 7 millimeter. And this 7. And in the middle, you see that we have no knot tying. So this is about 5 millimeter. So I have like 4 holes, but I have only 2 knots. Okay, so the knot will be just 50%, yeah, of the suture. Okay, instead of 8 holes, I put only 4 holes. So that will have less trauma to your rotator cuff. Okay, so this is a concept of the blended suture bridge technique. Okay, so now I tie the knot in the front. Yeah. Okay, this is my black, right? So the black is always I tie the back one. Okay, here. So we use the anterior as a post. จับดี Okay. ถูกไหม นี่ as a post. Yeah.
You know, the tissue is not good, so will you use a regeneratin for this kind of tissue?
Yeah. You asking me?
Yeah.
Actually, if the tissue is very bad and the cup is like degenerate, not torn, I just put ligenitin on the top without the knot tying. Or you just do some like side to side. Yeah. So if the tissue is very bad, especially the bursal side. Yeah. So like this cadaver, when I get in, we found that his tissue is like this bad. So if this is the situation, we don't need to take down the rotator cuff. We just repair it, right, without not tying. Just put ligenitin on the top. Or you can do like minimal cup repair, like side to side. Okay. So here you see it's become 2. You see here? 2. And this one is 2. Okay. This one is 2 now. Okay. So each hole of the cup will become 2, 2, and 2. Then I cook this to the front. Yeah. Okay. And next one. This one here, the black one. Yeah. Black one here. So now, if you choose the wrong post, this will become 4. So don't choose the wrong post. You should the posterior post, this one, right? This one will become your post, okay? So that will distribute the suture nicely, yeah. So I know that Hilo, you like to put the suture to the lateral row first, right? And then you just tie the knot. You do the knot tying later, right? I heard from my fellows. Yeah. So that's also a good idea, I think. Yeah. But in case you have some key stitch, like you have L shape, I always tie the knot at the apex of the tear first. Okay, that's nice. And next step is to do the lateral row fixation. Okay. So good. X rotate. Okay. Suture retriever. Okay. So we take one sutures here. Okay. For this. Okay. And then you take one by one. This one. Okay. This one. Also this one. Hey, chập đi. Okay. Good. So now we distribute the suture nicely. I use the cannula, okay, as a guide here, going to the lateral this way. I go to the most. But careful, you should look at your bicep, okay? Give me RF, okay? So don't put this into your bicep because the patient will have so much pain. You're performing the bicep tenodesis, okay? Okay, showing you. This is a bicep, blue. Okay, X rotate. Yeah, this is the bicep. Okay, I open the bicep for you. This is transverse ligament, yellow. Yeah. Yeah, just showing you that we are not in the bicipital group. Yeah. Okay, here is the bicipital group, right? And bicep is just next, right? But if you already cut your biceps, that's fine. Sometimes I put my anchors into bicipital group because the bone quality in the group is very good. Yeah. Okay, stop here, yellow. Okay, stop. So my first anchor will be here, right? The most anterior part. So you judge this here, this one. Nice. Hold this. Okay. Then we abduct the shoulder. Yeah, we're going down around 1 to 1.5 centimeters. เฮ้ยไม่ใช่อย่างนี้ค้อนมา Okay. Now we do external rotation for the anterior anchor. Okay, hold this. ไม่ใช่ footprint peak. This is helicoid knotless. รู้อยู่ไหน Yeah. ได้ยังได้ยัง Okay. อ่ะไป Multifix Ultra มีไหม Multifix Ultra I show you different kind of anchors. This is helicoid knotless. You can put 8 sutures. Yeah, like Ekavit, he like to put many sutures. Like Ekavit, you told me you can put like 8 sutures.
Up to 9.
Up to 9.
Yeah.
Oh my God, Ekavit, you're the God.
But
Oh, this.
it's already past 9. Oh, okay.
Oh my God. Okay. So look at the suture suture distribution, right? So sometimes before you going to the lateral row, make sure that your suture distribute nicely. But if not, you need to distribute the suture first. Sometimes it's not equal, so I will retension. Okay, make the suture nicely distribute, right? Like this. I try to cover, yeah. And then tension the suture one by one. Okay. Let's go. Next one. Go. Okay. This one. Nice. Okay. Next one. Okay. Next one. Okay. Good. Okay. You tension all the sutures for this. ถือกล้องดีๆนะค้อนมา So you turn the orange. See? Look at my hand. You see? Turn the orange. This is also allowed to bone in growth. Yeah. Okay. Until the laser mark. Okay. And then you lock the black one. Okay. Until you hear the click. Okay. Good. Ready? Out. Okay. So this we call helicoid knotless. Multipix ultra. Jima. And then next one. Blue. So we call this comb the hair. Okay. Comb the hair to make it handsome. And okay, next one. ขัดใจนี่ทำไมไม่เตรียมมาวะ Okay. Then we go and internal rotations. RF please. Okay, to the posterior part. So the posterior part, if you're close to the infraspinatus insertion, the bone quality is good. Yeah. Ekavit, you like to put it in the middle, right?
Yes. I
Ekavit.
use only one.
Only one. But the problem that in the middle from the study, the bone quality sometimes is soft. You have that problem, Ekavit, sometimes.
Yes. So
The bone in the middle.
I try to put it a little lower, and I found,
Lower, right?
Yes, I found
Yeah.
another problem. Sometimes it's too strong for the lower
Okay,
part.
too strong. Yeah. Lower sometimes too strong. I agree because you're close to the diaphysis, right?
Yes.
Yeah. Here I getting close to this is infraspinatus. So this area is close to the cortex. The bone quality will be good, right? I show you this is the infraspinatus, right? If you get close to it, yeah, you get the good bone quality, right? So the good bone is in the front, close to the bicep groove, and in the back, close to the infraspinatus insertion. Okay, that's good. And then you look at your suture configuration. We do Kennedy. Do Kennedy. Okay, like this. Okay, จับกล้องดีๆมาค้อนมา ได้ไหมขอดูหน่อย I try to make this in the same level. Same level? Okay? Okay ไหม Okay? ได้ยัง
Lower.
Lower, okay. Ekavit not happy. So I go lower for you, Ekavit. Nata, you okay?
Okay for now, but I could not see the infraspinatus.
Okay, I show you later. You should imagine.
Yeah, usually we can see the fiber and the one vessel.
Yeah. Thank you, Nata. My fellow fault, he called the camera. Seksan, it's your fault. Nata not happy. Hilo, you happy, Hilo?
I'm perfectly happy.
Thank you. Hilo always very kind. See, hold this for me. จับกล้องดีๆ we do can นะ okay good yeah that's a hole okay we tap first คอนมา okay and then hold this for me then I look at the cuff suture distribution okay so the gap between the suture should be equal okay hold this sometimes you get the dog ear so you should solve the problem right now because when you tension the suture you cannot solve this problem yeah so 1 2 3 and 4 that's fine can do see the black suture is okay is that okay ดียัง huh okay to the back right here yeah so I try to spread this a little to the back like this right yeah so David said I should move this back a little to the back okay and then tension okay go one by one nice okay next one hold this right go the leg is good now yeah let's go 3 and then 4 nice okay stop and hold this for me hold this Ekavit, you do decubitors, right?
Yep.
You have any problem to rotate the shoulder internal or external when you're going to do the lateral?
We can rotate
No?
the shoulder. I'm at this point. I may ask my scrub nurse to.
Yes.
I prepare everything.
Not your fellow.
Because I only have one assistant. You have 5.
No.
So I have
No,
one
Ekavit.
assistant, and the scrub will help me to rotate the arm at this point.
Okay. You don't love your fellow, right?
No. He hold the camera for me at this point.
Okay. Good. Okay, click now. Good. And you're also very kind to your fellow, right?
Not really.
Yes. Okay, now I think we finish.
Very nice.
I'm going to check the cup again because of the tissue qualities. Okay, IF please. I will do the regenitin next. Blue. Okay. So you see the tissue of this tissue cadaver had not so good. You have some tissue here you see this bad tissues because of the chronic impingement. Yeah. So next step is after you finish this, okay? So next step is I will find my rotator cuff, okay, axis. Yeah. I put the switching stick in, yeah, here, okay, and see my rotator cuff. Yeah. I prefer to put in the middle like this, okay? So when you got this picture, my fellow will not rotate anymore. You hold this and give me a pen. Yeah. Don't move. Okay. Draw this line. Yeah. Parallel to your, yeah. This is the line of your regenitin. Okay. So when you get in, you will follow this line. Okay. Good. And then give me the cannula. So this cannula, mostly I use the same cannula as my rotator cuff, but the key point is that you must do it just in front of the bone, just in front of your AC joint or your acromion, because you need very, very perpendicular trajectory, okay, like that, yeah. So this one is important, okay, take out. Nice, okay, and then you can identify here, if you put regenitin, proximal, distal, it should be good. I think trajectory is very important. You need to be, you see that I just in front of my bone, yeah, so that's the point, okay.
So for
Okay.
the trajectory, it's good for the anterior staple,
please.
right? How
I am-
about the back staple?
That's right. The posterior also, I do the internal rotation with like this. Okay, like this. I can put the anchor in the back also. Yeah, for this traction. And then the next one is my lateral portal here. I put this in. Make sure that I have very nice no soft tissue bridge. Okay, make sure you can get this well. You can do some dilatation because after this you will put the bone staple. Yeah, I think this is free now, right? And in the same axis of the rotator cuff. Okay, you agree? So now Regeniten. Yeah, we put this in without anchor. You see that black suture. That black suture is the anterior part of the cuff. Okay, so it just next to the bicep. Okay, now traction. We should do can. Okay, and then unlock, yeah, unlock. Okay, so then we inhale rotation. Okay, 1, 2, 3. Okay, that's nice. Okay, very nice. So I put the switching stick in like that. Okay. Okay, good. So that is the, and then you look at the most lateral. Looking at that, we do can. Okay, this is the, okay, that's good. Yeah, we go a bit to the lateral. So you need to, not too medial because you cannot put the bone staple on the lateral. Okay. So sometimes I just put the, yeah, this is the absorbable staple. Let's go. Good. Squeeze. Okay. First one. Second. บีบให้มันแนบหน่อย Okay, internal rotation a little ดีๆหน่อยไปหลังนิดนึง Okay ดีๆ go squeeze Okay แนบๆนะ Okay, nice. Okay, next one. Yeah, here. Okay. Then you spread nice, spread. Okay. You can spread it using this as the spreader. Push in the soft tissue. Okay, very good. And then going to the back here. Sometimes you can use the switching stick to put this down. Okay. Okay. And don't go to the blue. Okay. Up. Nap. Go. Squeeze.
Why don't go to the blue?
Because you can torn. It can be torn. It's too close to the rim. Ekavit. They decide to let you go to the white tissue. Is that okay? Every time you push and you feel, is it the tendon or bone? Yeah, this is the bone, right? It's the bone. Tissue is here. Okay. Now, we sing a lot now. Okay, in the middle one more. ตรงกลางดีกว่าเดี๋ยวจันถอยก่อน Okay, go. We have 8 totally. Let's go. Yeah. กดดีๆ กดดีๆ Okay. Okay, now switching stick. Hold this. จับกล้อง ถอยหลังนิดนึง Now you put this in, yeah, and then you hold this โทษนะดูกล้องดีๆจับนี้กดให้อาจารย์ Okay, yeah, look at this, yeah, and slowly take this out, yeah, that's fine. Good. And then we put another one in the middle. Okay, เฮ้ยแขนดูดีๆ Okay, that's good. Okay, put in the middle. ดีๆดูแขนหน่อย Okay, good. V ป่ะ internal rotation, internal rotation, very good. Okay, in the middle. Okay, tendon ไหม Okay, more proximal ตรงกลางmore proximal บอกปล่อยได้ไหม Okay, go. Yes, okay. We can put one more here. Yeah. ดูแขนหน่อยช่วยดูหน่อย โอเคเทนดอนไหมโอเคแนบpush okay nice okay now we got 6 and 8 now yeah 7 and next we can go to the velocity right on the lateral side and then abduction a little yeah like that good so make sure that this incision is big enough give me a small มีดมานิ่งๆนะเรคคอร์ดอย่างเนี้ยโอเคโปรแกรมให้อาจารย์นะ make sure that you have enough because the bone staple it's a bit bigger I mean the introducer is a bit bigger yeah okay nice okay now we in yeah release okay good yeah we can go front and back here slowly here make sure that you're on the bone okay okay that's good okay bye. Stop okay and you look at this it's nice a little กระเด็นใส่หน้าอาจารย์ okay good and then I squeeze don't move right go okay นิ่งๆนะเฮ้ยไม่เข้าว่ะเข้าป่ะเนี่ยthe bone is too strong sorry my fault the bone is too strong we try again okay on this side so mostly the cadaver bone is soft but this time too strong ไปตอกให้ชิดโอเคจบยังช่วยกดด้วยนะอย่าให้ขยับโอเคอย่าขยับเร็วนิ่งsure that's nice okay so I try again here so actually we can do one more here so มีอีกไหม we have in the set we have 3ได้ไหมno so sorry Egawit my fault
That's good enough. Don't worry.
Here I move here okay I try again go หลอดออกมา go ตอกเบาๆมาเข้าไหมแต่นิ่งๆให้อาจารย์นะโอ้โห very strong ดีๆนะไปเร็วแนบยังชัวร์โอเคไป oh that's good yeah so we have lateral nicely okay and then check the attachment right genital so you can move the shoulder okay hogging yeah into external rotation you see there's no impingement yeah of your regenital to the roof okay that's nice yeah make sure uh-huh ไม่ต้อง so sometimes you can let the bleeding into the regenital I show you spinal needle yeah because if you have like tissue degeneration like you have intertendinous tear of the อะไรกันนู้นออกนะ intertendinous tear of the rotator cuff I will do this later right we do the puncture okay so the blood from the rotator cuff will get into this regenital like Shannon lecture this morning right you need to have the cells of blood from the rotator cuff penetrate into the regenital yeah so that will promote the healing yeah okay like that next good okay so then we get into the joint again switching stigma with single rod yeah รูนี้ใช่ไหมรูนี้เนาะรูนี้เนาะ okay now I go into the joint again under vision ใส่จันน้ำเข้าหน้าเช็ดหน้าหน่อย so this is intraocular view หน้าเช็ดหน้าหน่อยจมูกด้วยโอเค so
เดี๋ยวผม
switching
พาไป
stick
ล้างหน้านะพี่
อะไรนะ
พาไปอาบน้
เอกเดี๋ยวออนไลน์นะออนไลน์นะโอเคไหน green noise there okay the supraspinatus and right your bicep okay 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 you get into the joint again here under vision right that would be safe เช็ดหน้าจานอีกหน่อยนึง okay so you check again make sure that your biceps is not included in your regenital repair okay so that is my bicep landmark okay okay you see that the bicep is still there right no anchor on the bicep right be safe and then we check at your attachment of the rotator cuff at the footprint you see it look nice compressed right no gap okay under the cuff okay bicep is still there right okay thank you so much thank you so much thank you all the team thank you Smith&Nephew and also thank you Hero Natta and Dr. Ekawit any questions now
any question or suggestion Hiro
อาจารย์สวัสดีครับ
Pancha, how do you manage the biceps?
so depends on the bicep pathology so if the patient had bicep problem and the patient still young I do bicep tenodesis okay if not the patient older patient I do bicep tenotomy yeah so my way of bicep I do transhumeral bicep tenodesis we do transhumeral I don't like to have anchors on the bicep or suture on the bicep we like to put bicep into the bone same like you Hilo you also make transhumeral right bicep tenodesis
Yeah, I routinely perform bicep tenodesis.
or routinely
Yeah.
wow How about Ekavit and Nata?
Oh, I like to use anchor, but I tend to save the biceps because if the quality is still okay, I
Yes.
keep it. But if I need to do tenodesis, I use a suture anchor at the groove.
Anchor. You mean you do onlay, right? Bicep tenodesis?
Correct.
Onlay on the bone, on the groove.
Yes.
Yeah.
Yeah, usually
Nata also use screw, right? For bicep.
screw for the stronger guys.
Yeah.
Not athlete. I use an anchor. And for the tenodesis, depend on the pathoanatomy of the biceps.
Yes. So I myself, I prefer to use the footprint PK from the Smith&Nephew because the anchor is like this, you have some spine. So once you get in, the bicep will be locked by this footprint PK. I don't like to use screw because when you turn the screw, the bicep always spin around your bicep. Yeah.
Okay. One last question, Tim. You plan to ask something?
Yes. This is Dr. Tim. สวัส
เสี
ดี
ยง
ครับอาจารย์
echo ครับ
So regarding
ใครเอ่ย
the Tim ครับอาจารย์ครับ
Tim
ครับ regarding the placement of regenerative position I saw that you put also cover the lateral roll is there any
Yeah.
technique that you can avoid the jamming of the lateral roll and bone anchor or
Yeah, very good question. So Tim, actually we did not do this routinely. So if you're dealing with the patient that have like type 2 tear, okay, the tear size is more proximal, I will not put my ankle that far. Okay, I focus on the medial side. Sometimes I did not put the staple, I mean the peak staple on the lateral side. So depends if you have medial pathology or you have mainly problem on your tendon, like you have abrasive tear or you have bad tissue, but you have good footprint at the lateral side. You don't need to go that far. Okay, that depends, Tim, on the pathology. If the pathology is more medial, you focus on medial side. Okay.
Right. Thank you. Let's move to the next session.
Thank you so much. Thank you. Thank you, the team. Thank you. Thank you, everyone. ขอบคุณ
Thank you,
ครับ ขอบคุณครับ
Professor Bansha. The next session is the topic for the Prof. Sugaya to share about the large and massive RCT in young patients.
Okay. Okay, I will speak about the large muscle rotary cuff tear in young patient, muscle advancement, extreme medialization, and SCR with without regenerative. These are Japanese perspective. These are my disclosures. Okay, iliperal muscle rotary cuff tear. We're talking about the iliperal muscle rotary cuff tear to first, but reverse is very famous. And in Japan, we started using reverse back in 2014. And normally the early 90s in the most European countries and mostly by early 2000 in other continent. What about in Thailand, reverse? When you guys started using?
I think about the same time.
Same, 2014 or something like that? Mm-hmm. Okay. All right, so no reverse for a long time. So that's why the unique procedures for massive rotary cuff tear is invented in Japan. These are examples that are arthroscopic patch replacements. Actually, I studied back around the year of 2000, and also arthroscopic superior capsule reconstruction, the Mihata, by Mihata, and also arthroscopic Debia Patte. This is muscle advancement. And also small head hemi-arthroplasty plus rotary cuff repair by Dr. Suenaga, and also arthroscopic rotary cuff transfer by Dr. Asato. These are not so famous procedure, but recently Dr. Mizuki started doing the arthroscopic extreme medialization. So this is arthroscopic patch replacement. I started this technique from 2002 using Teflon felt like that. And after 2009, I changed to the using the fascial adder. And in the meantime, of course, everybody knows that this is the outcome arthroscopic patch replacement. My former fellow Daisuke Mori presented and published papers back in 2013 and 15. And this is not excellent outcome, but acceptable outcomes. In the meantime, Teru Mihata started using, he invented the supercapsule reconstruction. This is the autograft patch technique, but this is very unique because he connected the patch between the greater tuberosity and glenoid. This is a supercapsule reconstruction procedure. This is everybody know that now. And also the Dr. Kurokawa in Kyoto University, Kyoto Municipal University, he started the modified Devere path procedure back in 1983. This is, of course, and at the time, the open procedure, but, original Devere and when compared with the original Devere or the original path procedure, he didn't perform the acromion osteotomy, and also his important thing is to preserve rhomboid and supra-infra junction, and also combined advancement of supra and infraspinatus. His young fellows studied the mini open the procedure. There's a modified Devere path procedure by Professor Kurokawa, and the mini open procedure they started in 2003, and also they published in the paper in a journal of orthopedic science. And the more recently, the one of the young guys in Kyoto Municipal University, Dr. Furukawa started an all arthroscopic procedure in the B-chair position. Actually, I prefer this procedure very well, and I'm following it for some patient. And all arthroscopic rotary cuff advancement is like this. This is a supra-infra is, preserving the connection of the supra-infra to the rhomboid muscle. And advancement performed like this. Also, interesting thing is the Dr. Mizuki. Mizuki studied the extreme medialization. He presented the arthroscopy technique back in 2022. Arthroscopic extreme medializer repair of massive rotary cuff tear, resection of cartilage and subchondral bone over the top of the humeral head. And he published the technique like this. And also 2023, he published an early outcome, clinical outcome. This is very interesting. 64 large and massive rotary cuff tears he incorporated. And also the mean age at the time of surgery was 68 years. And the mean follow-up was 6 months, more than 2 years follow-up. And UCLA ASES scores improved significantly, and the range of motions is forward flexion improved to 151 from 107, and abduction improved to 154 from 100, external rotation 41 from 41 to 47, internal rotation T10 level. And interestingly, the detail is only 2 shoulders, 3.1%. All massive and large tears. So this is very impressive outcome. And actually, I applied this extreme medialization for this patient. This is a revision case. Previous cuff tear failed. Actually, cuff repair. This patient underwent cuff repair 10 years ago. And now I mobilize the standards mobilization. I didn't release the muscle from the scapula fossa, no advancement, but mobility is very good. So the medialization performed like this, using the teasers like this. I'm following the Dr. Mizuki's technique exactly, like this. So actually the footprint area is maybe 15 millimeter, but 15 more, twice or maybe 3 times of the cartilage area resected. The X-ray is left side X-ray is before surgery. The right side X-ray is after surgery. So the resection, amount of resection, maybe you guys can understand. And also I take it out the one of the metal anchors. This is after resection. So I insert the tape anchor, 3 tape anchors, triple rolled, and prepare it like this. Okay, so the arthroscopic options for massive rotator cuff tears, arthroscopic superior capsular contraction and arthroscopic muscle advancement and arthroscopic extreme medialization. That's my, preferred methods. So the ideal indication of rotator cuff advancement, according to the papers published back in 2018 by Kyoto Municipal University team, is a tendon retraction up to the granular level. Boiro 3 is a good indication, and also Guttaria stage grade 2 and 3, and Hammer 3 without arthritis, and a good reparable SSC is a very good indication for muscle advancement. So that's why this procedure, Guttaria stage 4, is not included. So that's why the arthroscopic options for massive rotator cuff tear is these 3, but arthroscopic superior capsular reconstruction works well in patients with Guttaria stage 4. Okay, and after advancement and extreme medialization is indicated. For this procedure, we need to utilize an emerging rotator cuff. So that's why stage 4 is not a good candidate. So that's why to me, the indication of SCR and advancement and extreme medialization is clearly different. Okay, so the options for irreparable massive rotator cuff tears, reverse is elderly and poor function with pain. SCR using thick fascia lata, young active patient, fat cuff muscles. And repair with muscle advancement and extreme medialization, young and active patient, that fair cuff muscles, Guttaria stage 2 and 3. Okay, so what is a superior capsular reconstruction? The surgery to restore the superior stability in shoulder with a irreparable massive rotator cuff tears using thick, at least 8 millimeter and more thick fascia lata. Permihata invented, and also Tai Li also added the scientific background. And use of fascia lata is very important. Fascia lata, the 8 millimeter graft is the best, and the 6 millimeter graft is acceptable. So that's why maybe about around the 8 millimeter thickness of autograft fascia lata is necessary to perform this. The graft harvesting, the very large skin, 10 to 30 millimeter skin incision, like this. And one surgeon plus assistant is necessary. It requires 30-40 minutes, and graft harvesting and shaping. And the preparation of granular hemorrhage joint, and operator and the assistance is the preparation of during granular hemorrhage joint, and the grafting requires around about 1 hour. So total 2 hours for skilled surgeons and team. So graft harvest is like this, like that, like that. That they incorporate the pedicle. That is very important. Intramuscular septum, and the graft shaping and the preparation, and make 8 millimeter thickness, more than 8 millimeter thickness of graft. And we are using the 10 millimeter syringe to introduce the graft to the joint. So this is a biomechanical study. When compared with the fascia lata and the Dahmer arrow, this is very interesting. The Dahmer arrow is, to provide the mechanical test, the 15% of elongation. But in a fascia lata, no change. So this is very important evidence. So the fascia lata SCR is totally different from Dahmer arrow SCR. And actually, the literature, according to literatures, outcomes, Dahmer arrow, the failure rate is extremely high when compared with the fascia lata allograft. Okay, so fascia lata allograft SCR is very good, but the problem is concerns about the SCR. using fascia rara is donor site morbidity. Skilled, experienced harvesting surgeons are also necessary, and if otherwise, time-consuming surgery. So that's a concern. So therefore, currently we are seeking the potential of using thick graft from animal. This is, we call it supergraft. So Professor Kiyotaka Iwasaki in Waseda University he developed the technology of novel decellularized tissue with mechanical integrity and biocompatibility, and a decellularized xenograft. But he created the modern 10 millimeter thickness and mechanical integrity, and also the cold-like graft. So this comes from the animal. So that's why this is a xenograft, but the cellularized tissue. So that's why this is not the not the xenograft, and also of course not autograft and not allograft. So that's why we call that supergraft. So graft incorporation process using autograft is a decellularizing process. It normally takes 1 to 3 months. And then cell infiltration happens 3 to 6 months, and the maturation happens 2 years. So the immediate, this graft is because of decellularized tissue, so the immediate cell infiltration we can expect, and also no immune reaction because of decellularized graft. So that's why we are now doing the clinical test for the humans, especially the knee ACR reconstruction. But shoulder reconstruction using SCR will start maybe, I hope, within this year. Okay, so I think the supergraft is coming in future. Then we can avoid sacrificing the autograft. That's very important. Okay, thank you for your attention.
Okay, question? Any question? Okay, so the next session we will have a small debate regarding to Prof. Surya topic just now. So we will have a debate.
So from your slide, you mentioned about the choice of treatment between muscle sliding and you use the quality of the muscle, the grading of the muscle. So if you think grade 2 and 1 and 2, you still do muscle slide, but grade 3 and 4.
Muscle advancement, right?
Yeah, muscle advancement. But 3 and 4, you choose maybe SCR or something.
I think the SCR is very the condition of the good SCR, expecting good SCR outcome is good subscap or reparable subscap. But that's very important. But muscle supra-infra muscle grade stage 4 is also no problem SCR.
So this section is about a options for treat massive cuff tear. So Professor Sugaya would like to discuss and would like to share his idea and our idea from the floor also. So the indication and your experience you can share between this session. Okay.
What about the tendon transfer? You didn't mention about the tendon transfer. You like?
Sometimes I do. I do tendon transfer combined with the reverse for the external rotation restoration, and also I do for IRA case, isolated loss of external rotation case. I do lower trapezius transfer, but I don't perform the tendon transfer routinely for the massive reparable rotary cuff tears.
Can I ask the reason why?
I don't like the big surgery.
Excuse me. Let me make it the same concept. What's the definitions of young patients? Can you define young patients for making us know how young should we declare young?
Young patient is younger than Prof. Hilo. He's he's very young. He's too young.
Young patient is a young and active patient. Active guy. Yeah.
You have no cutting edge. No, because right now the people get younger even.
Yeah, because
We
I
cannot
have like patients
judge by
like
the age, I think.
68, but he's still like mountain climbers. So is it young? 68.
68 is very young, I think.
Right now.
All right.
Right
all
now.
right. All right. All right.
So I think you look at the quality of the tissue, look at the function of patient, bone quality. So you don't look at the age. I think we cannot judge.
So maybe it's a physiologic age.
I think so. Yeah.
Okay, please.
May I ask Dr. Sugaya, how far you? I asked about extreme medialization. How far you go to medial? What is your definition?
Based on the Dr. Mizuki, who invented the extreme medialization, he removed the cartilage maybe almost 1/3 of the human head. 1/3, yeah. The amount of the dissection is assessed during surgery, cutting, removing the bone, and when the patient placed the arm aside, exactly the cut level is same as glenoid height. So that's his assessment. But I think that's a little bit too much, my personal opinion. So that's why I prefer to dissect the little bit less.
So for the ideal patient who match with the excessive medialization, in your opinion, your ideal patient?
Based on the guys who were doing Dr. Mizuki and his group, and they said if the muscle remains, that is stage 3, 2, and 3, then every patient they can do. But that's according to them, the reverse indication is decreasing right now. But I think that's
MI should look very weird, right?
I think that's a little bit too much.
Too much.
Yeah, so that's why my preference is less resection, bone resection, and also reverse is reverse. SCR is SCR, so that we need to choose the proper patient.
Can you tell in millimeters how much he moved to the middle?
The
1 centimeter?
important thing is we need to preserve the lateral edge of the greater tuberosity.
Yeah.
Don't remove the lateral edge of the greater tuberosity. And remove the maybe the footprint area is 15 millimeter.
Yeah,
so
right.
I think in total 30 millimeter is good number, I think. But Dr. Mizuki is doing a little bit more.
Yeah.
But my indication is maybe 15 plus 15. 30
15
millimeter.
plus 15.
Yeah.
May I ask the question about the muscle advancement? Because from the previous talk, you did the muscle advancement plus regenerative on the lateral. How about the healing? Because we have the two ways of the blood supply from the footprint itself. Another one is from the origin of that you release the origin of that. So what do you think that the biologic from this condition that you release that and you put some pad on that, you think it's healed or not?
It's a very difficult question to answer, but as I show during my talk, the first talk, we experienced a 1 year patient, 1 year, and 5 patients we did in the more than 1 year follow-up, and failure rate was 40%, even using regenerative. So that's why we cannot expect the very good structural healing when compared with extreme medialization. So that's why I'm now I'm now shifting my mind a little bit. Yeah. So that's why I think the less resection of the greater humeral head bone and combined with the muscle advancement. So that's gonna be the very good.
So, which with the good result of you for 60%, do you have any common factors like is the younger patient age or is that the little release or what? Do you have any same common factors?
You know, when we see the 40% of the failure case, and also the success type 3 patient, then you know, human head is too large. So that's why I think came the idea to me. It came the idea that the resection, human head resection, is also very important factor. So that's why there may be combined procedure should be very nice. That's my. Still, you know, this idea is still developing. So that's why not my conclusion, but you know, right now I'm thinking like that.
Okay, I'm Dr. Pinit. I have the question for Dr. Sukaya. What is your tip and trick for the technique of the muscle advancement?
Technical
Yes,
trip?
Tip and trick
Technical tip?
for the surgical technique for the muscle advancement.
Yeah, muscle advancement. Actually, Dr. Furukawa started doing that, and he recently tells us the preserving the fascia without breathing, without creating breathing. So fascia, preserving fascia, and you know, fascia, and not go into the muscle, just to preserving fascia and just to reduce the together with the fascia. So that's why then we can prevent the bleeding. So that's why the you know, surgical time decreases a lot.
So that I understand is lie or not. We approach between the gynoid book and the capsule and keep to the bone and under the muscle of the supra, infra, and teres minor, all of this.
I don't understand.
So
you mean stay on the bone all the time, right? And how about the medial part? You need to make mini open or not? On the
No. Yeah, we're talking about the oral arthroscopic. So mini open is there, you know.
You stop.
Yeah, so they stopped the mini open procedure already.
Yeah.
So they started the oral arthroscopy from 2018.
So you release everything from here to the more medial part.
Yes.
Okay.
But you need to create a more medial portal.
Medial portal.
Yeah.
Oftentimes the tendon quality is not so good and very minimal tendon left. In case that you release the medial border and you can slide, but the tendon is not so good. What's your technique to fix the bad tendon to the remaining tuberosity?
You mean the tendinous portion, right?
Short tendon portion, right?
That happens.
Yeah.
But you know, if we can create a rest tension by reducing the muscle, then you know, maybe short tendon can work.
So and what is your position for fix the muscle as advancement?
Fixture position.
Yeah. Abduction.
Yeah, same. Same.
You need a brace after that. You need
yes, abduction brace.
How about the rehabilitation? Special one.
Basically the same. Little bit longer immobilization. Normally I immobilize 4 weeks after the surgery, until 4 weeks after surgery. Maybe some patient requires maybe 6 weeks immobilization.
I see you mentioned that you released the attachment of the proximal attachment of the supraspinatus, but you left the rhomboid attachment still there. Any problems with scapular biomechanics?
Maybe no. But important technical tips is also included the medial scapular border, rhomboid and the supra-infra attaches to very strongly to the medial scapular border. So releasing the medial scapular border, leaving connection, preserving connection, the rhomboid and the supra-infra is very important. One of the most important tips during the muscular advancement.
Dr. Sukri.
I want to ask the Dr. Bancha,
Yeah.
the latest case that I consult to you, do the ACR,
Yeah.
If you are the first doctor, what you do for this case? Do you remember Mr. Peter?
I cannot
you do
remember which
SCR.
one. Too many.
Peter from Pattaya.
Uh-huh. So can you briefly tell me again the history?
The car accident and
And?
the last hair and bad quality of the
He's a trainer, right?
Yeah, trainer,
Okay,
yes.
okay. So that patient have very big tear, supraspinatus, infraspinatus, and that retraction patellar and the cutalia is around 3 both. Yeah. So he's young and he's a trainer, muscular man, 52 or 53 years old. Yeah. So he did a good job at the first time, but finally it's failed because of I think the tissue quality is bad. So for me, maybe I do SCR at the first time because he has really high expectation. I did not try the muscle advancement. What do you think for the grade 3 Gutalier active trainer?
Once the patient failed.
Trauma.
It's trauma, yeah.
Trauma about
Trauma
4 weeks.
After
But I
surgery?
think maybe he has a problem about the shoulder also.
Yeah, I think he has some problem of the tendon before and precipitated by new trauma. Yeah.
If for the primary case, I
Yes.
do maybe muscle advancement combined with the extreme medialization.
Uh-huh.
But a failure case, I do SCR.
SCR. Yeah, I agree. He's too young to do any replacement. I think
Too
he need
active, man.
very active and very high expectation also. Good. Any more questions? Any question from the back? Most of them are the ex-fellow. I saw everyone is active. Members around Thailand, everywhere from Thailand, from the south, from the north, from the east. Any questions in your practice?
Maybe they are hungry.
Oh, they are hungry. I think so. It's time, right? So we are 12:15.
How many time we have?
12:15 exactly, right? So now 12:15. Okay.
Yeah. Thank you. I
Thank
think
you.
It's lunchtime.
Okay. Thank you. Thank you, everyone.
We will be back on
1:15 ค่ะ
1:15. Okay.
Okay ครับ ขอบคุณครับ
Thank you for
Thank you,
our
Kap.
speakers for the debate and the
Thank
participants
you.
that participate on this
ถ่ายรูป
session.
Below one picture.